Hi, Mike Gibson coming to you live from SCAI 2015, and I'm joined by Dr. Joe Loscalzo, Chairman of Medicine at the Brigham and Women's Hospital. Welcome, Joe.
Thank you.
Joe, you just gave one of the keynote lectures here, the Mullins Lecture, talking about network approaches to the redefinition of cardiovascular medicine. So talk to us about how our thinking about disease is evolving away from an organ-based approach, a la Osler, to more of a genomic or proteomic defined approach to disease.
Sure, Mike. I think we're all trapped in the 19th century formalism of how we define disease. And as you suggested, Osler really helped us along by defining disease on the basis of what he observed at autopsy and clinico-pathologic correlation. And as a result, our diseases are based on end organ, end of life phenotypes. And textbooks of medicine, departments of medicine, units in the NIH are all organized similarly. So we, also following Occam's razor, tend to try to force collections of signs and symptoms into those well-defined phenotypes because we would rather be inclusive than exclusive. Now, things have changed, though. I think that was a perfectly good way to define disease and think about therapies up through the end of the last century. Now we have much more rigorous molecular tools and genetic tools by which we can begin to characterize the subgroups. And after all, that's really the notion behind precision medicine, that better characterization of subclassifications of disease will give us a better understanding of potential therapeutic strategies.
Yeah, and I think the classic example, Joe, is, say, a lung cancer, and just thinking it's a cancer of the lung rather than it's an adenocarcinoma, and that could appear anywhere. And I think we're starting to learn through cancer very clearly that genetics plays a big role, right?
Absolutely. And in fact, the oncologists are thinking about the fact that not only can an adenocarcinoma appear in any organ, but there's certain types of molecular drivers of that adenocarcinoma, actually a limited number of them, probably 12 to 13 pathways that can produce an adenocarcinoma.
So in the future, we'll say you've got an adenocarcinoma with one of these 12 pathways, and that would then be how we might treat the patient.
Absolutely,
right.
Absolutely.
Yeah, and what organ it's in is just kind of...
Doesn't matter.
Now, how do we apply that kind of lesson to heart disease? I mean, I think we all have a sense that hypertension probably has a lot of mechanisms, hyperlipidemia, probably even heart failure. I mean, will we look back on how we've done all this 10, 15 years from now and kind of laugh?
Yeah, I think we're very likely to, or at least our children or grandchildren are likely to.
Yeah.
I think that most of the diseases that we classically view as cardiovascular diseases like hypertension or heart failure are really syndromes, or, if you will, super diseases within which there are going to be better defined subgroups. And these subgroups can be defined phenotypically, and we're making sort of a crude estimate at doing that in heart failure by distinguishing diastolic from systolic dysfunction and other subclassifications that are well known. But I would say even within those physiologic classifications, there will likely be many different molecular pathways.
Right.
So these are what you might call convergent phenotypes. A good example of that in the modern era is hypertrophic cardiomyopathy, right? Everybody who's got the disease, they may have slightly different abnormalities on echo, but if you do the biopsy, they'll have the same fiber disorganization, abnormalities in the sarcomere, but there are over 170 different mutations that cause hypertrophic cardiomyopathy, and they all have virtually the same kind of end organ pathophenotype. And that should lead one to believe that they're all converging on some common pathway. And it's up to the modern genomics people to sort out what those pathways are, which could give us much better insight into therapeutic strategies.
Right. So therapeutics, in terms of the right kind of pathophysiologic targets, for one thing, do you ever see a world where we use CRISPR or something to actually change the genotype to then alter the phenotype?
I think different strategies for genetic manipulation, I'm convinced, will certainly come to the fore in the next 20 years. CRISPR is one approach. The use of antisense is another approach, which is gaining a lot of traction.
Sure.
I think the challenges for those therapies really involve delivery to the right cells and the right genome at the right time. When you use an agent like an antisense, for the moment, there's no clear way to target its delivery unless you physically target it to the cell of interest. But there are strategies by which you can put such a drug as a payload into some delivery vehicle,
Right.
and then target it by
Right.
surface markers.
Right. Well, very brave new world. Any other future thoughts about where we're headed?
I would just add, as we're talking about therapy, that I think there's a growing sense that we need to consider rational polypharmacy, as I like to think about
Yes,
it. That
yeah.
we do it sort of semi-empirically now in the treatment of complex cardiovascular disease, but really from the perspective of end-stage pathophysiology, when we use a combination of vasodilators and antithrombotic agents for acute coronary syndromes. But I'm speaking more about using combinations of drugs that attack a pathway that might be driving a disease, as the cancer folks are trying to
Right.
do. I think that will also be in our bailiwick.
In a preventive
preventive
mode,
way,
rather
exactly.
than in an organ or end stage mode. Where do you see something like the PCSK9 inhibitors fitting in?
Well,
Something like that early on. I mean, it's fascinating to look at the genetic mutations conferring a lifelong benefit, and then we give these drugs at age 60 for 10 years of benefit. What if we backed up the clock?
Yeah. Well, that is a big challenge, and whether or not we can ever really realize preclinical therapies of that sort at an early enough stage to make a difference is really an open question, because
Right.
we really have no idea what the consequences of such lifelong therapy would be. That could be
But
adverse.
someone like with the PCSK9 genetic variants, they don't have neurocognitive defects that we
Yeah.
know of, et cetera. I mean, I know we're all a little nervous about that, but
Yeah.
they seem to be fairly healthy.
Yeah, no, I think that's true, and the more we get used to the use of monoclonals as therapeutic strategies for lots of different
You
targets.
turn on the TV and all you see is this, this monoclonal antibody.
Your
that one.
patients will ask you for a menu of monoclonals.
Exactly. Yeah.
Right.
Well, Joe, thanks for coming all the way out here to San Diego the Sky. It was a real highlight of the meeting having you here.
Thanks,
giving the
Mike.
lecture.
My
Good
pleasure.
seeing you again as always.
Thanks very
for
much.
joining us, and thanks to all of you for joining us here live from SCAI 2015.